Hello again and welcome to our video lecture on diabetes mellitus, where we're seeing alterations of the pancreas. So we know that diabetes mellitus is a metabolic disease and it's characterized by hyperglycemia. And we have defects within either insulin secretion, its insulin action, or both is taking place at the same time. And we classified them as 1, 2, or gestational. And there is a type 3 that is being discussed in research literature, but we're going to focus on what is established at the moment. So for type 1 diabetes, this is someone who has had an autoimmune reaction to the beta cells, and they are not able to produce insulin. And so we cannot attach to the insulin receptor in order to let glucose into the cell. I always talk about insulin as being the key to the inside of the cell to allow glucose to move in. And type 2 diabetes, this is caused by progressive loss of the beta cells and insulin secretion. And so we may be secreting some insulin, but unfortunately it's not able to attach to the receptor and allow the glucose in. And so we start forming an insulin resistance. And then we have gestational diabetes mellitus, which we're going to get into details on a future slide, but essentially it's diabetes that's diagnosed in the 2nd or 3rd semester of pregnancy that is not clearly overt diabetes before the person got pregnant. We'll start off talking about type 1 diabetes mellitus, and this is the most common pediatric chronic disease. And there are 2 distinct types within this type 1, and that is as idiopathic, which is rare. It most commonly occurs in people that have like an Asian or African descent, and there typically is no evidence of any type of autoimmunity that affected the beta cells. With our other type, we have autoimmune type 1, and in this type, we see that the humoral immunity is affected. There's autoantibodies that are against the islets of Langerhans cells, and insulin can be affected. Our glutamic acid decarboxylase, or also known as GAD, can be affected, and other cytoplasmic proteins that could be stimulated. So essentially the autoimmune reaction helps create an activation that is of our cellular immunity, where the macrophages and the cytotoxic T cells and those autoantibodies are attacking the beta cells, and about 80 to 90% of those cells are lost. And so our insulin synthesis is going to decline and hyperglycemia develops. So I put this little schematic here just as a reminder. When we do have high blood glucose, then our pancreas is going to secrete insulin from the beta cells, and that is going to allow the glucose from the blood to be moved into the cells, and then that brings us back down to a normal level. So if insulin is not working properly, we are going to keep this high blood glucose levels. Now I want to remind you of this other hormone too. When we have low blood glucose, our pancreas releases glucagon from the alpha cells, and that tells the liver to release glucose into the blood, and it does that through 2 different processes. It does it through glycogenolysis, where it's taking glycogen and breaking it down into smaller glucose molecules, and gluconeogenesis, where we're able to produce glucose using things like fat and protein. And with that, we are able to achieve a normal blood glucose level. So these 2 things are not turned on at the same time. When insulin is functioning normally, then it suppresses glucagon. And so when we have hypoinsulinemia, then we start to see a marked increase in glucagon. Now you may have seen over here that we also list this hormone or protein known as amylin. And amylin is going to be another beta cell hormone, and it is basically what I like to call the sister of insulin. It is going to essentially copy it. And so when amylin is inhibited, we will see a rise in glucagon as well. So just so we know what the role of amylin is that it will inhibit food intake, delay gastric emptying, and decrease the blood glucose levels, similar to insulin. So like we saw in the previous slide, in diabetes type 1, we have genetic and environmental factors that are involved, and we have a slew of clinical manifestations due to the insulin deficiency. First off is going to be hyperglycemia, which we kind of talked about in the previous slide of why we have that high blood sugar. Then we have polydipsia, and that's because water is osmotically attracted from the body cells to the blood. Because we've got so much sugar in the blood, water just wants to leave the cells and go to that area, and so that results in intracellular dehydration, and it stimulates thirst. Then we have polyuria, again, with so much sugar being in the blood, and the body within the kidneys is going to filter that blood, and glucose gets dumped into the renal tubules, and we try to reabsorb the glucose, but a lot of it gets left in those tubules, and so that sugar in the renal tubules pulls in the water, and essentially it's being a diuretic and causing these large amounts of water to then be lost within the urine. Then we have polyphagia. I talked about how back when we were in this previous slide here, how glucagon causes the liver to release glucose in two different ways, and one of those ways was gluconeogenesis, and that is going to lead to our polyphagia here, because we are depleting the cellular stores of our carbohydrates, our fats, our proteins, and essentially creating cellular starvation, which makes somebody very hungry or increases their appetite. And so that can then lead to weight loss, where we have fluid loss in our osmotic diuresis, but also a loss of our body tissue due to us using those fats and proteins to generate new glucose within the liver. Now we have no more fuels left, so that's going to lead to fatigue due to those metabolic changes and poor use of our food products. And then we can also have recurrent infections because we have a lowered immune system functioning. So growth of microorganisms can also be stimulated by increased levels of glucose levels. And lastly, we've got prolonged wound healing that is impaired due to our blood supply not functioning correctly and hindering that healing. Treatment for type 1 is to achieve optimal glucose level control so that all of these things can kind of go back in order. Next, let's switch into type 2 diabetes mellitus, where we're going to have insulin resistance and a decreased insulin secretion by the beta cells of the pancreas. And you could see here that we do have both genetic factors and environmental factors and obesity that play into this. So when we talk about genetic factors, there's actually been more than 60 genes that have been identified that are associated with type 2 diabetes, and it includes for those that have to do with the beta cell mass and the functioning of it. Some other risk factors that are going to play into it is having a family history of diabetes, your age, obesity, hypertension, having a poor diet. So if we have a diet that's high in fruits, vegetables, fiber, and nuts, we tend to have a reduced risk. But for those that have a poor diet, that maybe includes more simple carbohydrates or saturated fats and red meat, that will be associated with more of an increased risk, and a sedentary lifestyle, so physical inactivity. And then diet while somebody is pregnant may also have long-term effects on their child that they are pregnant with. So let's take a look at this schematic over here, which is on the pathophysiology of type 2 diabetes, where we are taking the genetic and environmental factors into play. We know that we're going to alter the insulin receptors. They're going to become more insensitive. Glucagon is going to increase. And then we have our adipokines, and these are essentially chemical messages that are sent out through the adipose tissue, and we can also increase the serum levels of leptin, which is going to be a hormone that is made by our fat cells to regulate long-term energy balance. Essentially, it's going to be able to influence things like our appetite, our satiety, our motivating behaviors toward our energy reserves, the fat that we store within our adipose cells. We'll have lower levels of amylin, which we've talked about in the previous slides, and then we're going to talk about incretins and ghrelin in the next slide. But essentially all of this is leading toward, either insulin resistance or decreasing that beta cell mass and function, which all in all turns into increasing the amount of blood glucose that we have, which results in inflammation, tissue damage, and organ dysfunction. So as one is pre-diabetic, they may have this initial insulin resistance going on, in which we have compensatory hyperinsulinemia that is preventing clinical appearance of diabetes. But as that continues, we can have loss of the beta cells, causing a deficiency of that insulin activity, and we can no longer keep that compensation going. So our gastrointestinal hormones then start to play a role in the insulin resistance as well. I mentioned ghrelin in the previous slide. This is a peptide that is produced in the stomach and from the pancreas that regulates our food intake, our energy balance, and hormonal secretions. And when we have decreased levels of this, it's associated with insulin resistance and increased fasting insulin levels. An incretin, on the other hand, is going to be a peptide as well that's secreted by the GI tract, and that responds to our food intake and the function to increase the secretion of insulin. The one that is written about the most is our glucagon-like peptide 1, or GLP-1, that has a responsiveness to reduce incidences of prediabetes and type 2 diabetes. So both of these are going to be affected when we start moving into insulin resistance. Now, our manifestations, these are non-specific, are things like fatigue, pruritus, and this is because having hyperglycemia is going to favor fungal growth, and so that can lead to more itching. Recurrent infections, we've kind of talked about this, where we have a decrease within our immune system response. Visual changes can take place, such as blurred vision, because we have a change within the water balance of the eye. It fluctuates because of our elevated blood glucose levels. We also have symptoms of neuropathy. We're going to talk more about that in a coming slide. And often the people are overweight or obese and can have dyslipidemic blood and be hypertensive, because diabetes contributes to a macrovascular disease where we get atherosclerotic plaques that start building upon the walls of the vessels. So the treatment, right now, metformin is the primary pharmacologic choice, and we also have pramlintide, which is a synthetic analog of amylin, which we said kind of mimics insulin. And just a little revisit of gestational diabetes here. That's any degree of glucose intolerance with the onset of first recognition during pregnancy. And here you could see that we do have the baby becoming affected because the increase in glucose levels will take place within the fetus as well. And then we've got maturity onset diabetes of youth, or MODY, and this is when our beta cell function or insulin action is affected by an autosomal dominant mutation. You could kind of see the schematic over here. So far we've talked about these polygenic forms. The monogenic form is where we're going to see that MODY settle, and you could see some of the more common mutations listed over here. And there have been at least 13 genetic mutations that affect critical enzymes that involve the beta cell functioning, so that when affected, we have the onset of diabetes. So we've already kind of talked about the manifestations of diabetes, but these are more of the acute complications, where we can also have hypoglycemia, which is also known as insulin shock or insulin reaction. And this is when we have a significant drop in blood sugar or blood glucose because of an unexpected change in either the person's food intake or exercise without modifying their dosing of insulin. So treatment would just be to immediately replace that glucose. Then we have diabetic ketoacidosis, or DKA, and this is when we have increases in the levels of insulin counter-regulatory hormones. So we're talking about catecholamines such as epinephrine or norepinephrine, cortisol, glucagon, or the growth hormone. And we do tend to see this happen more in people who have type 1 diabetes, although it can happen in type 2. But essentially we get a big change that is going to require us to go through lipolysis. If insulin was present, it typically inhibits lipolysis and we get lipogenesis instead. So as we know, in diabetes, insulin is at low levels, if at all, and so we get lipolysis that takes place, and that is going to cause a formation of beta hydroxybutyric and acetoacetic acids, which then leads to an accumulation of ketones within the blood and the urine, and this is going to be acidic, these ketones, causing a drop within the pH, and then we get our diabetic ketoacidosis, which causes the person to go through the Kushmal respirations to try and get rid of some of the acid by breathing it out. Lastly, here we have our hyperosmolar hyperglycemic non-ketotic syndrome, or HHNKS, which is going to be rare, although when it is experienced, there is a high mortality rate. And we tend to see these more with elderly patients, and they most likely have other comorbidities going on, including some type of infection or cardiovascular or renal disease. And so at this point, they have more of a mild to moderate type of insulin insufficiency. And we see this more with type 2 diabetes, whereas with our DKA, we saw more type 1 because it's a little bit more foregone as far as the insulin that they're secreting. So here we might have a lesser degree of insulin deficiency taking place, and we are going to develop hyperglycemia. Note that we don't have the process of lipolysis or the ketones developing here, so acidosis doesn't take place. But due to the hyperglycemia, we go through the route of having polyuria and as well as polydyspnea, causing a hyperosmolality, and the central nervous system becomes depressed. And so to manage this condition, we would want to include having lots of fluids, taking insulin, and having electrolyte replacement. Now moving into chronic complications, this gets a little bit more involved here. We've divided this out into microvascular disease and macrovascular disease. So with the microvascular disease, we start to see that there are complications within the capillaries. So there's occlusion taking place, there's ischemia and hypoxia taking place as well, and that can lead to things like diabetic retinopathy, nephropathy, and neuropathies. So regarding the retinopathy first, which we see pictured over here, this develops because we have hypoxemia taking place in these blood vessels here, damage to the retinal blood vessels, we start to get red blood cells aggregating, and also hypertension taking place. And so we can get new vessels developing on the vitreous humor because of the hypoxia that might be developing in those areas, and that may cause retinal detachment or hemorrhage into the vitreous humor, which could cause severe blurring or even loss of the vision. And diabetic retinopathy right now is the leading cause of blindness worldwide. Regarding diabetic nephropathy, we know that the blood has to filter through the glomeruli, right? The renal corpuscle. And when we have hyperglycemia taking place, they become injured when they have a protein there called advanced glycation end products, or AHS. And so with glycation taking place, it bonds glucose in the protein, and we start to have intraglomerular hypertension taking place, and we have high renal blood flow, causing hyperfiltration, and eventually we end up having glomerulosclerosis and glomerular perfusion and pressure changes that are going to affect the kidney. In diabetic neuropathy, we are going to see that there definitely is an effect on the nerves. We have that chronic hyperglycemia with ischemia cause demyelination that contributes to the neural changes and delayed conduction. We have a loss of pain, temperature, and vibration sensation before we start to see changes as far as motor involvement. And then we can have things on the neurons such as oxidative stress and poor perfusion as well, and a loss of nerve growth factor to recover from the damages. Now, for the macrovascular diseases, we know that there's accelerated atherosclerosis, which is going to lead to any of these conditions: cardiovascular disease, stroke, peripheral vascular disease. And especially within PVD, we are going to see that there are occlusions taking place in small arteries and arterioles that could lead to claudication, meaning that they get pain from reduced blood flow during any type of physical activity. We can also get ulcerations that develop and gangrene, and this is really what could lead someone to amputation. Infection, we've talked a lot about already. We have impaired immunity, tissue ischemia, and recurrent trauma to certain tissues, and delayed wound healing that all contribute to multiple infections.